There we go. Trapdoor 1. 4 centimetre testis mass with a 34-year-old male. Now you can see here this has a distinctly glandular architecture, this tumour. And if we look at higher power, I can show you some things. You can all make up your own mind as to what you think this is. What a tubular architecture. This is a tubular pattern seminoma. Now I wanted to draw this to your attention as a very unusual pattern of seminoma. Now let's go back to basics. One thing we did in WHO 2022 is to try and think about the nomenclature a little better. Basically, these tumours, whether they be germinomas in the pituitary, seminomas in the testis, or dysgerminomas in the ovary, are basically the same tumour. In the thorax, they're still, in the lung team, we still call them seminoma for reasons that defy gravity. What I did do in the 2022 is call seminoma in the germinoma family of tumours, because they're all closely related. And this is a typical seminoma. It's got a fibrous band on the left. You've got lymphocytic associated with it. You've got these cleared cells with a very boxed off cytoplasm. And I draw your attention to these nuclei. I'm not sure whether you can see my arrow, but the nuclei are very polygonal, with often a squash tomato-like appearance of a nucleolus, sort of a straight edge, rounded edge. It's a very classic appearance. That's it at higher power. Again, you can see this sort of rather polygonal pattern. And often it's the cytology, I think, that can help you more in a difficult seminoma case. This is a seminoma case which is sneaky. It is not intratubular, intertubular. So you've got GCNIS or intratubular seminoma really in these cells here. And associated with these Leydig cells, you have this insidious infiltrating seminoma cells in a commonly misunderstood pattern. It's missed frequently in mixed tumours. This slide looks a bit off. The reason for that is that it's about 70 or 80 years old. This is a case from the British Testicular Tumour Panel, which is done in the 50s, amazingly, and it's kept its H&E. I think some of these hand stainings were really very good if they're stored away and don't go off as much as current ones. I showed this slide. It's a nice example of a granuloma and a seminoma. You've got this lovely granuloma in the middle, and the inflammation is not always lymphocytic. It can be granulomatous, and this can fool you. This is another alarming example of intertubular seminoma, where you've got the OCT4 positive cells infiltrating around these quite normal seminiferous tubules, so it can be quite infiltrative. And this is another pattern. This is from a slide actually from my good friend Tom Albright, who I'm sure you've all heard of, from Indiana. And this is the signet ring variant. Now, signet ring variant is never pure, but if you look, you can see seminoma cells with this signet ring appearance that could potentially fool you into thinking of something else. Another thing that can fool you is trophoblastic cells in the seminoma. Seminoma can have syncytial trophoblastic cells in them. Shouldn't have cytotrophoblastic cells, really. And this is important because if you give a diagnosis of choriocarcinoma, the patient may undergo a much more rigorous, nasty chemotherapy than they have seminoma and overtreated. Overtreatment is something we're very keen to avoid now in germ cell tumours. So I'm sorry, you're going to have to get used to my sense of humour. I can't resist saying I'm not a choriocarcinoma for this little chappy here. But a modest rise in HCG is fairly common in seminomas. If you look hard, you'll see these guys. So, how not to miss a seminoma? OCT4 is a really good stain. Obviously, it stains both seminoma and embryonal, but CD30 can help you out there in differentiating embryonal positivity. CD117 will be positive in the seminoma, negative in the embryonal. There are a few traps there. CD117 is sometimes positive in immature Sertoli cells. CD30 can stain activated lymphocytes and macrophages. OCT4 is often your best bet. It does stain other things, but mostly embryonal and seminoma. Cytokeratins, normally negative in seminoma, but can be positive, about 5 to 10%. AFP and glypican-3 are another thing we'll talk about later on, but obviously they should be negative in a seminoma. So that's your first trapdoor. Your second trapdoor, this is a slightly similar looking case, really. 24-year-old, 4-centimeter testis mass, which looked rather variegated, and the markers were not done. Always, by the way, ask for your serum markers. I get a lot of referral cases, and it really winds me up slightly, I must say, if the serum markers haven't been sent as well, because that really can help you. It's not cheating, it's helping you. So let's have a look at this tumour. This is a solid pattern of yolk sac tumour. I'm going to go back there. So yolk sac tumour is among a tumour which is extremely different in how it looks, extremely polymorphous. Yolk sac is notoriously different in how it looks, and it can mimic areas of seminoma. It's just a bit more monomorphic and a bit more bland than you'd expect in a seminoma. Now, how can you avoid making this mistake? Well, first of all, you look for more classic areas of yolk sac tumour. You can see on the left the classic Schiller-Duval bodies. On the right, hyaline globules classically associated with this, which are PAS positive, and another Schiller-Duval body. And it's got a much more variegated, often microcystic apparent, and a little bit blander in its morphology than a seminoma or embryonal carcinoma. Now, these are all the different types of yolk sac tumour that are enumerated. Is this scary? Yes, it is. Do you need to know it? Probably not. I always forget one or two whenever I write out this list. I think the important thing to know is that yolk sac can be extremely variegated in its pattern. However, knowing the serum AFP can really lead you in the right direction here. I wouldn't be calling a tumour without any yolk sac components if the AFP was very high without a lot of thought behind it. So do look at your serology. So, how not to miss? Serum markers, immunochemistry. I think it's important to choose the correct blocks as well, AFP and glypican. Glypican, so to talk a little bit about them both, AFP is not a particularly sensitive marker in that it can be very, very focal, even in areas of classic yolk sac. Glypican-3 normally is much more sensitive, but it lacks specificity. It does stain other things as well. Also, I've seen cases where the best blocks haven't been chosen. Sometimes it might be worth, if it's possible, if you're allowed to, do it on 2 or 3 blocks, or just mark suspicious areas on the H&E to make sure you don't miss areas of yolk sac. Does it matter? Well, in a seminoma, if you find yolk sac, yes, it does, because it'll be a different line of treatment. It'll go along a non-seminomatous treatment if chemotherapy is needed rather than a seminomatous one. If it's in a non-seminoma itself, it may not matter that much, missing a little bit of yolk sac. I get a lot of referral cases, and I don't sort of beat the drum on this too much, but look at your serum markers, and it can really help you find the areas of yolk sac in your tumour. Right, we'll go on to trapdoor 3. So trapdoor 3, this is a real case, obviously. A man with hematemesis in a 24-year-old male who had a stomach biopsy. This case arrived not in my department, but in another department in 1998, 1999, soon after I'd become a consultant. And it was called a squamous cell carcinoma. Now, we may think this is silly, but you know, you're on a busy clinic, it's a wet Tuesday, I know you probably have fewer wet days than we do here. And it's miserable out, and you don't think, and you don't trigger, it's a 24-year-old male. This is not a squamous cell carcinoma. This is metastatic choriocarcinoma. Now, metastatic choriocarcinoma is an area where you can save a life. Now, I've seen metastatic choriocarcinoma quite a few times in my career, but I've never, ever seen a pure choriocarcinoma in the testis itself. By the time it's become that big and taken over, it's metastasized widely, and normally it's diagnosed on metastases. The case on the left, you can see here, there's some teratoma there on the left. But this unique mixture of cytotrophoblast and cytotrophoblast, often associated with hemorrhage and necrosis, is a unique thing. Going back to this patient who was diagnosed with squamous cell carcinoma, fortunately, a clinician thought this isn't right and ordered a feature HCG and spoke to me. And I called it choriocarcinoma based on A, the morphology, B, the immunochemistry, and C, an HCG of about 200,000, something silly like that. Now, this man had metastases everywhere. He had them in his brain, he had them in his stomach, he had them all over his bowel, etc., etc. And if he'd had a squame, he would have not been given the right chemotherapy. He would have been put on a palliative pathway. Because he had the right chemotherapy under my close colleague, Jonathan Shamash, we're 26, 27 years post this diagnosis, he's still alive today. I'm very pleased to say he's had a number of metastatectomies, including of the brain and bits of his stomach and things like that for residual teratoma. But he's doing well and I think cured of his disease, we can say. So this is an area where you can save a life. It's also an area where the biopsy won't necessarily go to the GU pathologist. It makes the point to me that despite the fact that sometimes we are very extreme specialists, we must keep a slightly broad base at the bottom so we don't forget some important things, like if you have a cancer in a young man, what to think. And similarly, I think as GU pathologists, we have to remember our gynae pathology and thoracic sometimes, so we're not fooled out. That's something that worries me about specialization, which we can chat about later if you wish. Trophoblastic tumors are divided into choriocarcinoma and the non-choriocarcinomatous trophoblastic tumors. This isn't, I can tell you, I don't know if I can tell you, but I'm going to anyway. It's not going to change vastly, I don't think, in the next WHO. The main thing to worry about is choriocarcinoma. Cystic trophoblastic occurs after chemotherapy. Epithelial trophoblastic and placental site trophoblastic are extremely rare entities I've only encountered on rare occasion. So how not to miss this? As I said, clinical awareness is really important in other specialties. We are clinicians and have to think like them. I always like to think if you're an A&E, or if you ever were an A&E and had a young man come in with multiple metastases like this, you don't even have to send off a blood test. You just do a pregnancy test. If the pregnancy test is positive, he's got metastatic choriocarcinoma. So there's a thought for you. Immunochemistry for chorio. HCG is a really dirty stain. I don't like it particularly. It does stain everything sometimes. GATA3 does stain up these. Inhibin, P53 in a biphasic pattern. Sometimes I even use Ki67, which can be helpful in the cystic trophoblastic ones. But the main things are morphology again. GATA3, Inhibin, P53 are what I use. Trapdoor 4. So this is a 21-year-old man, 5-centimeter testis mass. Now you can see something very unusual about this. First of all, it's a partial orchidectomy. We are doing more partial orchidectomies for lesions we're not confident about to preserve fertility in the UK, and having quite a lot of success with it. My thought with a partial is that they can be done and we can go back to the specimen later on once it's, pardon me, to do a completion necessary. Some centres do frozens on them. I'm not a fan of that, I must say. I think doing a frozen on a really challenging case can be extremely tricky. And I don't think there is any danger to the patient for usually a highly curable tumour if we take it out and then get it worked up properly rather than trying to guess on a frozen. There are all sorts of entities which look like each other these days. We have to be careful. You can see it's a teratoma, but this is an unusual teratoma, isn't it? On the left-hand side here, it's got hair in it. Now, you often see hair in ovarian dermoid cysts, but how often have you seen hair in a real post-pubertal type teratoma of the testis? And on the right, you can see that the pilosebaceous unit and the sebaceous unit there is very well formed, much more formed than you'd expect in a teratoma of usual type in the testis. You can even get cartilage in these lesions as well. You can get all three layers represented. They're extremely mature, as you can see. I hope you can see bottom left that testicular seminiferous tubules are preserved in there, and there is some spermatogenesis there. And the diagnosis of this lesion is a prepubertal type teratoma. Now, there are lots of caveats on this diagnosis I want to make because it's a bit of a flashy diagnosis. We worked together with a number of people, Tom Albright, Liang Cheng, Michelle, on this about 10, 15 years ago now, supporting the fact they exist. And I hope you know that most germ cell tumours are isochromosome 12p positive. They have this specific isochromosome. This is mainly present in what we call the type 2 germ cell tumours. These are the adult ones that arise post-pubertally. The prepubertal ones do not have such a genetic association. And in fact, in the prepubertal age group, a teratoma or a yolk sac is basically benign. They don't metastasize. There are virtually no recorded deaths. And they are isochromosome 12p negative. So occasionally, these mature teratomas can persist into adult life. And that's why we call these post-pubertal type, prepubertal type teratomas, because they occur in the post-pubertal testis. I hope that's clear. They are rare. And if you diagnose them, you have to make sure that you exclude a number of things. First of all, there must be no germ cell neoplasia in situ present. If there is, it's a post-pubertal type teratoma. There must be no immature areas. I'm thinking of primitive or what we now call embryonic neuroectoderm. There must be no regressive or scarring changes there. And preferably, but not necessarily, no isochromosome 12p. I used to do isochromosome 12p regularly. I don't now because I'm slightly more confident on this. I've had a number of people over the years come up to me and say, I've got a prepubertal type teratoma and it metastasized. And I said, well, send me it. Let's have a look. I've yet to have everyone follow up on this. I think that nearly all of these lesions, or in fact, if it's a prepubertal type teratoma, it's benign. If it's a post-pubertal type teratoma, it's definitely not benign. It has a risk of metastasis. Now, epidermoid and dermoid cysts are really variants of prepubertal type teratoma. Epidermoid when it's just basically an epidermoid cyst in the testis, and dermoid cyst when there might be other skin appendage elements. They're easier in a way. It's harder when there's cartilage and other mesenchymal elements there. What's the importance of making this diagnosis? Well, for the patient, it's very important because they have a benign versus malignant diagnosis. And secondly, follow-up schedules. Obviously, they get CTs, etc., if they've got teratoma, if they've got a post-pubertal type teratoma. So I think it's an important but rare diagnosis to make. However, I would emphasize, if in doubt, you should always call it a post-pubertal type teratoma with follow-up. How not to miss. It's a diagnosis of exclusion. Do your best to try and make it post-pubertal. Find that GCNIS, look for the immaturity, hunt for GCNIS on all blocks. A little extra follow-up and scanning is not going to matter hugely. But if you can make the diagnosis, it's nice to give the patient a benign diagnosis, as I said. So prepubertal type teratomas, I think definitely are a thing, but you should have strict criteria for the diagnosis. Trapdoor number 5, a macro of a mass in the testis. And you can see this fibrous scar in the testis. There seems to be a second bit to it there, a bit of yellowing there. So this is a difficult situation, which I think we sometimes encounter. You get these fibrous scars in the testis. There's a bit of hemosiderin here. There's these coarse calcifications, bottom left. And if you look very hard, I think I cut it out. Yes, there was a little bit of teratoma in the bottom left one, which I sneakily cut out. So it just looks like scarring. Well, what is this? I think one has to always think in a scar whether this could be a regressed germ cell tumor, because this again has serious clinical consequences. Have a high index of suspicion for sclerosed and necrotic areas in the testis. Search very carefully for GCNIS. Look for other stigmata, any necrotic tumor, coarse calcification, atrophy. And of course, look at the clinical. What are the markers and imaging? They could well have, or they might have, a large metastatic deposit in their retroperitoneum or worse, liver or something like that. So check the clinical. Entirely block the specimen is really worthwhile just to check there's no GCNIS or anything lurking. One must remember, I think, more and more these days that a tumor does not necessarily start as one cell with doubling every 24 hours or whatever until it becomes a billion million cells. It relapses and remits because of the tumor host interaction. And I think that the recent data on lymphocytic response and PD-L1 has shown how plastic this response is. And testis tumors are very prone to this relapsing and remitting course. Now, after you've done this, occasionally you can't be sure. If they've scanned retroperitoneum, there's nothing there, it's a scar, there's a suspicious feature like coarse calcification, I will say that I can't exclude a regressed tumor and follow-up is advised. I must say this is a caution of mine, but I think we'll have to be very careful if you see these scars in the testis, unless, of course, you've got a good history of trauma from the patient, which is, again, why clinical is all important. So, trapdoor number 6. Don't worry, there's going to be a long trapdoor in a while. 56-year-old, that's a clue, isn't it? With a 6 centimetre testis mass. This is a spermatocytic tumour. I want to talk in a bit of detail about spermatocytic tumour. It's a rare entity. I don't know how many of you've seen them, but they have a very characteristic morphology. You have big cells like this one there, medium cells and small cells. They are far more polymorphous than a seminoma or really any other germ cell tumour. They often have vacuolated cells with this spirine chromatin. There's the medium cells, here's the smaller cells there. They often have microcystic areas. And just to fool you further, they can be present in the tubules. So this is not GCNIS, this is intratubular spermatocytic tumour. And it leads to many cases being called occasionally seminoma I've seen over the years. Now let's go back here a little bit. I want you to note this is an atypical mitosis you could possibly see, I think, in this spermatocytic tumor. Spermatocytic tumors are almost always benign, but we'll come back to that in a minute, but they're almost always benign. I know of no other typically benign tumor that typically has atypical mitoses. I see atypical mitosis in spermatocytic tumors much, much more than I do in seminomas or embryonals. So there's food for thought. If you can think of any such tumor, do tell me, because no one's been able to yet. So we renamed this in 2015 as a spermatocytic tumor. It used to be called spermatocytic seminoma, which was definitely a misnomer. And it did lead to people mistreating patients. What's the immunochemistry of spermatocytic tumor? Well, it's OP4 negative is the important thing. But CD117 is pretty often positive, normally in a rather more granular appearance like this slide than the more membranous type of staining you get in a seminoma, but it's often there. Now, I want to tell you about this case. So I was confidently diagnosing, this is a trapdoor I fell in, or very nearly anyway. I confidently diagnosed spermatocytic tumor in a man in his 30s. And we sent him away, and he came back with hemoptysis. And they did a chest X-ray in his chest, and they found a huge tumor there of about 8 centimeters in size. And of course, they told me, and I felt, frankly, as sick as a dog. I thought, what have I done wrong? So I said, well, we'd better get this tumor out and have a look at it. So we had a look at this tumor, and to my amazement, it was a spermatocytic tumor. There was no doubt on the morphology. It was identical to the primary tumor. So what was going on here? I think one little paradigm of medicine is that, you may not believe a black swan exists, but you only need to see one to find out they do exist. And so I thought, well, maybe this is a true metastatic spermatocytic seminoma. So we did some genetics on it, and much to my amazement, it showed isochromosome 12p. So we wrote this in pathology about 5 years ago. Metastatic spermatocytic tumor with hybrid genetics, breaking the rules in germ cell tumors. I would add here that these tumors can metastasize often when they show sarcomatoid change. If you see a sarcomatoid area in a spermatocytic, then that's often a bad sign, but this had no sarcomatoid areas. So we thought we ought to take this a bit further. And so again, we all clubbed together. Sunak Gupta and Andres Acosta ran this study looking at genomic analysis of spermatocytic tumors with clinical behavior, with malignant clinical behavior. And it showed a range of changes that was associated with malignant behavior. This include gain of isochromosome 12p, a strong expression of p53. And we produced a nice little pathway for us to show that p53, ploidy shift, and a number of other alterations might lead to sarcomatoid transformation and metastatic spread. This was published in Journal of Pathology 24, January 24, I think. But anyway, so it's a trapdoor I fell in, but we learned a lot from it, in that I think that typical spermatocytics, if they've got nothing wrong with them, we can still say follow up. There's no need for routine follow-up, but maybe we need to do a bit more on the ones that show p53 abnormalities, that show isochromosome 12p abnormalities, if you can get it, and certainly on the ones that show sarcomatoid transformation. The one thing to say is what you do about it, because the chemotherapy doesn't seem to work on these tumors. To go back to my case, the tumor came out, and this man has not recurred since. So it's almost like it's an embolic phenomenon rather than a true metastasis. This is me speculating, really, but it's an exceptional case and shows you how there's no end to the fun in germ cell tumors, and there's no end to the possibilities of making an idiot of yourself in public with this metastasizing spermatocytic tumor. So, how not to miss? Morphology: IHC, OCT4 negative, CD117 positive, lack of GCNIS, but be careful, it's not intratubular spermatocytic tumor. And in unusual cases, consider, if you've got it, doing isochromosome 12p testing and p53 analysis, as this might indicate more aggressive behavior. I'm going to check the time. We're doing well, that's fine. Trapdoors 7. This is a 24-year-old with a germ cell tumor, and 4 years later, he had a metastasis excised. I hope you can see on the left, you've got fairly typical embryonal carcinoma with a pseudoglandular appearance. The right looks far more blue, frankly, looks far more compact. It looks different. And this is what was then called somatic transformation to a primitive neuroectodermal tumor. And I'm going to do that to it because we're having some name changes here around somatic transformation that I want to draw to your attention. So this, what was previously called PNET, can come in many varieties with homorovite rosettes, tubules, or with this primitive neuronal embryonic morphology. Now, about 5 years ago, 6 years ago, Michelle Hirsch, a good friend, Tom Albright again, and Trevor Flood, who's a gynepathologist, wrote this paper in Amj Surg Path. Embryonic type neuroectodermal tumor should replace primitive neuroectodermal tumor of the testis and gynecological tract. And we did this for a number of reasons. The so-called PNET only existed now in the testis. It had been removed as an entity in the WHO CNS system. So I'm not going to talk too much about the rather terrible names they have, but PNET was replaced by embryonal tumor with multi-layered rosettes and based again on genetics. Ewing sarcoma and PNET, they were realized to be really separate entities in 2013. Now, Ewing sarcoma, you can rarely get in the testis, but now they have the ESWR1 Fly1 fusion if you do get one. But the testicular ones really resemble CNS tumors and not Ewing's, so it should be perfectly possible to separate them. And it's the same as what we call immature teratoma, not a term I like, in the ovary as well. So we recommended not calling these things PNET anymore, but embryonic time neuroectodermal tumor. And we made this change in both the AFIT volume and the WHO 2022 at the same time. So there was an unusual degree of concordance on this and getting PNET out, as it was no longer a primary CNS entity. They've changed the name again in CNS, but it's not back to PNET. I hope that makes sense to you. The other thing I want to talk about is the term teratoma with somatic malignancy. There have been papers from a number of groups over the years suggesting that in your chemistry, these tumors with somatic transformation don't necessarily arise in teratoma, and suggesting that they arise from yolk sac, often with sarcomatoid or with glandular morphology. And this has been followed up on genetics, particularly by Daniel Nettersheim and Felix Bremer. And they've shown by genetics that, in fact, most sarcomas may be teratoma derived, but the glandular lesions are often yolk sac derived. And the other paper that's key to this is work by Nick Wyverkins, who worked with Andres Acosta from Indiana, and the great and much lamented Chris Fletcher as well on that paper. to show that these tumours often had more in common with their germ cell tumours than they did with the somatic malignancy. And I'll try and explain that a bit further. In that germ cell tumours with somatic malignancy often go wild. They've got widespread aneuploidy, a distinct epigenetic signature, and mutations that are rare in testicular tumours without it. However, there is a similarity of mutational and DNA methylation profiles of different types of somatic transformation, which means that its identification matters more than its precise histological subclassification. What do I mean by this? I mean that if you do find somatic transformation in a germ cell tumour, then don't worry too much about complete subclassification according to the system of the organ. For instance, if you find a nasty rhabdoid sarcomatoid tumour, it doesn't matter what type of rhabdomyosarcoma it is, it's just a nasty rhabdomyosarcomatous type transformation. So we can't subclassify them. They don't necessarily have the genetic events that one sees in their somatic counterparts. They have more in common in a way with the germ cell tumour, which is primary, and with their somatic counterparts. Because of this, Tom, Mohamed Idris, João Lobo, Daniel, me, and Andres Acosta wrote this suggestion that we reappraise the name of so-called somatic type transformations. Because, as I said, they retain many things, including isochromosome 12p and KIT and KRAS mutations. So it isn't similar to the somatic cancer in terms of behavior and treatment. And we're reduced to overclassifying. It can be really challenging to put these tumours in the right box. Because of this, we suggested this. The first thing we suggested as well is that it no longer be called teratoma with somatic malignancy. We call it germ cell tumour with somatic malignancy. And secondly, we propose changing the names. For instance, somatic type rhabdomyosarcoma should be changed to sarcoma-like tumour of germ cell origin of a rhabdomyoblastic phenotype, etc., etc. Somatic type squamous cell carcinoma becomes a carcinoma-like tumour of germ cell origin with squamous phenotype. And I think that's rather slightly more cumbersome and descriptive, but what it does is it gives ownership back to the germ cell oncologists and clinicians, because this is a germ cell tumour. It's not necessarily going to have the genetics and behaviour of the primary somatic tumour it resembles. And we know there are far more targets now to various fusions, etc. We don't want to go down that route. We want to think of these as germ cell tumours with a very aggressive course that need to be treated more like germ cell tumours than their somatic counterpoint. So I'm going to go on to the criteria for somatic transformation, which is important. Now, most are diagnosed in metastases in the secondary, and occasionally they're diagnosed in the primary testes. Now, the important thing to realize is these are separate things, different situations, but called the same thing, and they need to be carefully distinguished. I don't know if I've got the slide. I have got the slide. I'll go back. Sorry. Okay, I'll move on. So how do you diagnose somatic transformation? So the old way used to be on low power field diameters. The trouble was in WHO 22 is that the low power field diameters varied from microscope to microscope. So we decided to use 5mm cutoff or overgrowth, but not on much evidence. And there's no real data on ovarian germ cell tumours. So what I'm telling you basically is the criteria for somatic transformation are not absolutely great. However, what I can tell you, due to this paper and my own data, which agrees with this by João Lobo, is that in the primary situation, if you have somatic transformation in the testis, it does very well. On the whole, if you have somatic transformation at a distant site, it behaves aggressively and does more poorly. So you have to distinguish these two situations. And if I see somatic transformation in a primary testis, I tell the clinician, just do what you'd do if it was a normal germ cell tumour. Don't do anything differently yet. So how not to miss a somatic transformation? Somatic transformation in the primary, I believe, may be treated conservatively, with the caveat that if you're in Indiana, I know they do a prophylactic primary RPLND to exclude a metastasis. I think this is overkill, but watch this space. There's further work to do there. When in a metastatic situation, you look for overgrowth rather than organoid pattern of mixed elements. You need not overclassify, is the good news. Sometimes salvage germ cell therapy can be efficacious in these tumours. It's not a time to go straight over to the sarcoma or adenotype chemo straight away, but undoubtedly they have greatly reduced survival. This is a complicated area, so do feel free to come back to me on this area later on if you want to. I've got one more quickie and then we've got the big trapdoor. This is trapdoor 8, ovarian mass in a 23-year-old female. AFP is normal. And dysgerminoma, she had a dysgerminoma with unusual areas seen, and you can see the sort of biphasic pattern here of these cleared cells with these immature looking cells around the outside. That's a picture of the fallopian tube and the little funny area seen next to it. Here's another example of this sort of lobulated tumor with coarse calcification in it. And this is a gonadoblastoma. Now, gonadoblastomas are fascinating but very interesting tumors that are not to miss, especially if you get a dysgerminoma of the ovary. They're described by Scully. They occur in dysgenetic gonads. It's a disorder or difference of sexual development. Even though it's female, a Y chromosome is always present. 80% are in female, but 20% are in males, and it's an abnormality of the TSPY1 gene. So there are a number of importances of gonadoblastoma. The most important thing about gonadoblastoma is that if you find gonadoblastoma in one gonad, there is a huge risk of a later germ cell tumor, particularly dysgerminoma or seminoma, and that both gonads need to be removed. It can be quite challenging, gonadoblastoma. There have been a number of articles about the dissecting variant, which I can show you here, in which the nests of these mixed germ cells and Sertoli cells or immature sex cord cells are very small, but they're still cut up into nests rather than the invasive true seminoma or dysgerminoma patterns. This is a rare problem, but I have seen it. But it's an important distinction to make, because if you've got an invasive dysgerminoma, then you might consider adjuvant chemotherapy. If you've just got a gonadoblastoma, it's essentially a benign entity with a preneoplastic entity rather than an invasive entity. So it might affect treatment. But these can be very difficult. But you can see the arrows pointing to these little immature Sertoli cells, which are there present with the germ cells. How not to miss dysgerminoma? In men, it's always cryptorchid and intra-abdominal testes. So always think twice about cryptorchid and intra-abdominal testes. And my 10th trapdoor will be something similar. In women, dysgerminoma should always trigger a search. Please block your dysgerminomas in young patients to look for gonadoblastomas. IHC should look for immature sex cord cells around islands, plus OCT4 for the dysgerminoma/seminoma cells. If I'm doing this, I always send to my peds colleagues. There are very few experts in pediatric testis. Miguel Reyes Mujica, who works now in Florida, is an amazing man who's done a lot of the work here. But I will show this around if you have one of these cases to my peds colleagues. The DSDs, as you'll see in my last case, are a fascinating area. Okay, I hope I've got till another half hour or so, because this is the big one I want to go through with you, which is risk factors and identifying vascular invasion in germ cell tumours, before my 10th one, which is very short. Vascular invasion is often overcalled in testis or miscalled. This area here, you can see you've got these rather epithelioid cells in a vessel next to the testis, and you can see the CD38. Macrophages are a common mimic of vascular invasion in germ cell tumours. So that's a no, it's not vascular invasion. Whereas here you have this horrible embryonal carcinoma, but it's clearly in a vessel. It's attached to the side. It's got blood associated with it. This is clearly vascular invasion. And this is a clear example of vascular invasion. So there are some criteria for vascular invasion here. It's got to occupy a lymphovascular structure with flattened endothelial cells. That's to avoid it being a sort of artifactual shape. It may not conform to the exact shape. Preferably, there should be some fibrinous thrombosis there. There needs to be a lack of background artificial deposition of germ cell tumour cells. One big problem with germ cells is I think occasionally the surgeon takes it off and it sits on a hot room uncut for a while. And when the tumours open up, especially if it's seminoma, it sort of splurges out like a sort of porridge over the surfaces of the testis. And this can make vascular invasion really, really difficult to look for. Looking for LVI is difficult. I would also say, don't say suspicious of, very suspicious of, I'm not sure. Unless you're absolutely convinced, call it negative. If you're convinced it's an LVI, call it positive. This is for a very simple reason. Saying I'm not sure is just not helpful to the clinicians. They don't know what to do. The guts, all the... Can someone mute her, please? Thank you. So I'm not sure is not allowed. Try and be definite. I know that can be difficult. I want to talk a little bit about work I've done in risk factors, because this is crucially important to how we treat germ cell neoplasia and a pathologist's role. After an orchidectomy, about 20 to 30% of tumours without any metastases do relapse. The question is, who is going to relapse and who isn't? So if you do relapse, or at high risk of relapse, there is a reason to give a chemotherapy as a prophylactic chemotherapy, adjuvant chemotherapy. But more and more we are surveying these patients. Is there a way we can de-escalate or target de-escalate the low risk ones and escalate the high risk ones? So there have been a number of previous studies on this. Some have compared the pathology in metastatic and non-metastatic disease. And this is what I've done, but also Indiana and Toronto have done of it, with variable reporting of all clinical and pathological data. But comparing a stage 2 from a stage 1 tumor is not the same as a prospective study. The second one is an oncologist-driven project. Now, this is when I get angry, because what oncologists sometimes do is they collect all the cases and read all the reports from multiple institutions with no thought at all, asking the pathologists to be involved. And this results in bad data. The third thing is relapse data is often not good because of poor follow-up, variable administration of therapy. Some people get extra therapy, some don't. The other thing is I had a big fight with the UICC TNM 8th edition, where in oncologists, I've been very nasty to them there, but honestly, trying to get them to adopt the ISEP regulations in the AJCC TNM has been a big fight, which we've won, but we'll go on to that. So I was very lucky that I worked with a cohort in Denmark. Now, Denmark always survey all of their patients. They never give any treatment. So it's a really good cohort to look at. So we looked at clinical stage 1 patients. We were blinded to clinical outcome and did a medical record review with a big cohort of both seminoma and non-seminoma. One thing that's often confused, I would say, in germ cell tumours is retestis involvement. And this is one of the reasons why retestis has often had variable outcome data in the studies that have been previously done. People mix up stromal invasion, which you can see at the bottom, with pagetoid invasion. You can see these pagetoid cells here running around the retestis. This is basically GCNIS, we believe. So these were mixed up in previous studies, often, especially the oncologist-driven ones. So we wanted to prove this was a mistake. The other thing that's ignored in previous studies is hilar soft tissue invasion. Now, I don't need to tell you that in the kidney, hilar soft tissue invasion is a very important prognostic factor. To me, it was therefore unsurprising that invasion of the hilum of the testis with its big amount of vessels in there would probably be a poor risk factor. And this is what we found in the stage 1, stage 2 studies, and the battle I had with the TNM system to add hilar soft tissue invasion as in the TNM staging system. So we made strict rules. You can see the tunica vaginalis at the bottom. This is no perforation, therefore this is not T2. And what we did was we looked at absolutely everything in this study to cut a long story short. We did hundreds of factors. I want to draw your attention to a few things that we found. First of all, look at the difference between pagetoid retestis involvement that has absolutely no prognostic significance and retestis invasion. Here we have absolute proof that retestis invasion of a seminoma is a strong prognostic factor. Tumour size was a prognostic factor. And this is our final multivariable Cox model for this study. And it is, I think, with 924 patients, 16% relapse rate, one of the biggest studies that'll ever be done. And what we showed is there are 4 basic factors. One is the invasion of the hilum, either with the rete or the hilar soft tissue. Second, LVI. And in fact, previously, studies have been equivocal on whether seminoma vascular invasion was identifiable. Thirdly and fourthly, and very interestingly, the serological levels of beta HCG and LDH were independent prognostic factors. So this enabled us to do a study, tables in our paper. This is in JCO in 2024, where we could very much improve on our prognostication of a seminoma to improve treatment. There are 4 factors there. You can got the red dots if both factors are present, the black dots if one factor is present. There you go. So for instance, the number at risk, if you've got no factors, you only have a 6% chance of relapse. So obviously giving any extra therapy in this circumstance would be a mistake. However, if you have all factors present, and granted that's very few of these patients, you have a 60% chance of relapse. And maybe it would be worth giving an adjuvant treatment like adjuvant carboplatin, which we do in the UK a lot for these patients. So this is a really important, I think, diagram that can show how we can refine things better. I want to just move on now to give you the findings of the non-seminoma. This is just the multivariable model. You'll be unsurprised that LVI was highly prognostically significant. Also, hilar soft tissue invasion and tumour size was significant. Also, we divided the percentage of embryonal carcinoma into absent, non-predominant, which means not the highest percentage, or predominant. So when you do your non-seminoma assessments, do give percentages of the different elements. You needn't be exact, it can be ballpark, but do say whether embryonal is in the majority, the minority, or absent. That will help construct these curves in the future. And there's our curves for non-seminomatous treatments, and you can see it varies a great deal between 5% with no factors, which is a very low factor despite the fact it's a non-seminoma, to an amazing 85% chance of relapse with all the factors present. So we identified new prognostic lactation factors. They link in quite nicely, and it does have clinical implications for how these are treated. It does improve on the previous prognostic models. We're trying to sell it to the oncologists. In my routine practice, I'm part of a MDT, multidisciplinary tumor meeting, which looks at about 20 to 30 germ cell tumors a week, believe it or not. And we risk stage all of our patients to try and give the patients informed information on whether they should have adjuvant chemotherapy or not. So that's my PhD student, Thomas Wagner, who I worked with on this study. He did the legwork. He looked at thousands and thousands of tumors, and I helped him out on the difficult cases and the cases. And it was run by Getske Daugard, who's an oncologist in Denmark. But it was a great pleasure and honor to be involved in this project. So, how not to miss any of this? Don't call lymphovascular invasion unless you're sure. Fix the testis well. And to be honest with you, I have no worries if a surgeon bivalves the testis before it comes to me if there's going to be a delay. I prefer if it was well fixed. The typing and the LVI call is much more important than actual the margin outside the tunica, which is never involved anyway. Fortunately, do look at the TNM9 classification, which does have soft tissue invasion and stromal rete invasion included. It has soft tissue invasion included as T2. And measure well, measure your tumor extensively well. That's another story I'll come to another day, but it can be difficult. I think that you'll notice in the seminoma study that LDH came out better than tumor size in the multivariate. I think that's because it's often difficult to measure seminomas, especially if it's intertubular, sorry. So the LDH is a surrogate for the size of the tumor. Now, with a few minutes left, and then we can go to questions, I'd like to go into my last trapdoor, which will show you how interesting testicular tumor is, I believe. This was a 48-year-old male, not in my institution, who had a metastatic germ cell tumor. He had a fascinating history. He had a history of undescended testes noted at birth. They couldn't be found, so prostheses were inserted, and they never actually went back. This is, remember, over 50 years ago now. He had, despite the fact his testes hadn't descended, he had a normal puberty. He developed a hair and a moustache. He got a job. And then he developed a metastatic germ cell tumor with a very high HCG. And he had chemotherapy. And after chemotherapy, residual masses were removed from his pelvis. I've suggested, asked cheekily for a karyotype here. So these were the masses that were removed from the pelvis. On the right, you can see a tumor mass that was basically a residual choriocarcinoma. On the left, you can see what looks very like fallopian tubes, a uterus going into a cervical-like structure, and a second gonad. So this caused big surprises to the surgeon who went in for this surgery. What is going on here? There's this man's procannabral metastases. There's this mass which obscured all else. There's the HCG and the choriocarcinoma. This case we did write up. We called this a patient with persistent Müllerian duct syndrome. What is this caused by? Well, interestingly, this man has a normal XY karyotype. The reason why he has this is he has a lack of anti-Müllerian hormone or its receptor protein. It's not an androgen problem. As I mentioned, he developed a moustache, he developed a normal penis, he developed normally. But because he has a defect in the anti-Müllerian hormone pathway, his female genitalia do not shrivel up and stay patent. And therefore the testes don't descend. And because the testes don't descend, that's what puts you at risk of a germ cell tumor. So this is a little taster of the fascinating world of disorders of sexual development, which always amaze me. I'm not an expert, but they are absolutely fascinating. And there's something new around the corner every time you see one of these. So that's my 10 testicular trapdoors. I've shown you some common things and some quite difficult and challenging things. So I'd like to thank you for listening, and I'd welcome any questions you might have.
Thank you very much, Professor Berney, for the invaluable presentation. And we will now open the floor for our Q&A session, as we have quite a number of them coming from our colleagues. And I will read them through the submissions sequentially. There are two participants quite experienced similar situation, so I'll group these questions into one. So one participant said his case of germ cell tumor submitted in its entirety shows tumor cells that looks like seminoma with syncytial trophoblasts and HCG around 9,000. Another participant experienced quite similar situation where there was absence of trophoblastic component in her case with HCG, HGC, apologies, around 8,000. They both saw no choriocarcinoma. For the first participant asked, could this still be pure seminoma? Or they are both wondering whether they missed something.
Point well taken. I think it could be seminoma. I have seen rises of this magnitude, and I've seen no choreo. I think the important thing is to, I'll move that out the way. I think the important thing is to try, in a tumor which is so highly curable, to try and give them the least toxic chemotherapy if possible. So I would suggest that unless they've got definite syncytial trophoblasts there, to keep calling it seminoma with syncytial trophoblasts. If it goes up to sort of 500,000, I think obviously you think again. But I think 9,000. I think I've seen that sort of level in a seminoma.
Right, and the second question, participant asks, how do you decide whether the tumor is prepubertal? Is it based on age only, or yeah?
So prepubertally, you haven't got a problem. Prepubertal, it'll always be a prepubertal type teratoma. Postpubertally, about 95–98% of tumors will be a postpubertal type teratoma. A small percentage will be a prepubertal type. That's why we use the word type there, prepubertal type. This is a diagnosis of exclusion, and what you have to do is you have all the things I mentioned. You have no GCNAS, you have maturity, you have no regression in the primary tumor, you have no atrophy there, and preferably no isochromosome 12p. I've also seen you had, Paolo, I've seen you had an area that looked like carcinoid. This is interesting. Please read my paper in Modern Pathology from a few years ago. I found about a quarter of my prepubertal type teratomas had small areas of neuroectodermal tumor. Of net in them. So they're tiny little carcinoid-like things. Very common in a prepubertal teratoma, much more common than in a postpubertal teratoma. So it's not just age. I hope that comes across.
Another question, how do you differentiate GCNIS and maturation arrest at spermatogonia stage?
So OCT4 is a perfect marker for GCNIS in adults. The only caveat I'd put this on is if you do a prepubertal testis, it might also be expressing OCT4, but you never do it on those. So if you have a postpubertal testis, I agree that sometimes it can be really difficult to distinguish GCNIS from some forms of spermatogenesis. Do an OCT4 if you're in doubt. The only times you need to do it in specific cases, I don't think you need to do it in every case of germ cell tumor, but an OCT4 is really, really helpful. Don't do CD117 because CD117 can mark up immature Sertoli cells. You can do PLAP if you want to, but I find the basic is. Oh, I'm echoing. Someone's got unmuted. I do find that. Where was I? Basically, a nuclear marker always trumps a cytoplasmic marker in my simplistic ballpark. So I think OCT4 is the best marker for that.
Next question is I would like to ask about how you determine different components in mixed germ cell tumor. Is it morphology alone sufficient, or do you always use IHC?
So that's Jurasit. Hi, that's a very good question. I will be entirely honest with you. When I started this job, I did immunochemistry on absolutely everything. And then after about 5 years, I stopped because I gained confidence. So the thing about germ cell tumors is that even if you're a specialist geopathologist, you may only see a few a year. So don't be ashamed or worried if you need to do immunochemistry. I think once you gain experience and you're seeing, like I am, 200-300 a year, it's a different kettle of fish, and I can be more confident, especially if I have the markers available. So the morphology alone is sufficient, but do immunochemistry if you need to. I sometimes do, sometimes I don't. But most of the time I don't these days, I confess. But there's no shame in doing immunochemistry on a case.
Next question, how do you differentiate gonadoblastoma from GCNAS if the basement membrane material or calcifications is not apparent?
So they look very different. So GCNAS will be in normal-sized seminiferous tubules in a normal descended testis. Gonadoblastoma will inevitably, when you get your hackles raised for gonadoblastoma in bilateral undescended testes cases in a male, which is rare, in a young, very young person, possibly prepubertal, or in a female in a dysgerminoma case. But in your regular testis case, where the balls are in the testis, if you'll pardon my, in the scrotum, if you'll pardon my language, it's not going to happen. But it's often a much more complicated pattern with a lot of scarring and a lot of enlargement and coarse calcification. And you don't really see those in the regular testis.
And the last question, how do you distinguish pure choriocarcinoma from embryonal carcinoma with in situ fibroblastic giant cells, both morphologically and immunohistochemically aspects?
Thank you, Chan. I've never seen a pure choriocarcinoma of the testis. I've only ever seen it in a metastatic site. It's the first thing to see. How do I find pure choriocarcinoma morphologically? Areas of necrosis, areas of hemorrhage, syncytial trophoblastic cells. There, I agree with this. Syncytial trophoblastic cells away. It's often like that. If I'm in doubt, I'll do immunochemistry. Obviously, the pure chorio will not have CD30 positive or OCT4 positive. The embryonal carcinoma will be. So there's good immunochemical ways you can distinguish them. It's not been a huge problem for me. I would add that these are both non-seminomatous germ cell tumors. So it's not going to change too much in what happens to the patient. I do try and think about how the patient will be treated. There are some where it's an important tipping point, like, for instance, the cases that Jarasit and Zara mentioned, where you've got seminoma versus chorio. That's an important distinction. for the treatment pathway. But if it's embryonal versus choreo, it's much less important. I hope that makes sense.
Thank you, everyone, for the questions. It's right near the end of the webinar. I would like to invite Dr. Ann Litte, one of the SEAUPS founders, to deliver this closing remarks for this webinar.
Thank you so much for the introduction, Meiji. Yeah, good evening, dear esteemed colleagues. Thank you. I want to extend a sincere thank you to our distinguished guest and also our distinguished speaker, Prof. Berney. Thank you so much for your kind contribution and also expertise. It is an honor for us as a society, a new society actually in the world. Your continued support to us is very meaningful, much appreciated. And having you today, 1.5 hours for me, really, is just really fast one. Thank you so much. Your lectures hopefully can be very useful for us, especially that are really rely on morphology. And testicular tumor is absolutely not an easy one. I do agree with you, Professor. Thank you so much.
Thank you very much. Indeed, it's been a pleasure.
Thank you. Yeah, it's really honor to have you. Also, I would like to thank you, the educational team that I know worked hard for preparing this meeting and webinar. And also, thank you, Meiji, as our new moderator. Thank you so much for your contribution. And the most important is all the participants. I saw it's more than 100
wow.
today. Yeah, indeed. And we are very happy. Hopefully, this will help us as a pathologist for our daily practice. Thank you. And for your active participation by asking and having reaction. Thank you so much. And I would like to invite you for our next webinar of SEAUPS and ISUP, as you can see at the monitor. The next webinar is a collaboration from SEAUPS and ISUP with the title Practical Diagnosis of Genitourinary Cancer, Bridging the Gaps in Low and Middle Income Countries. It's really related to us in the Southeast Asia region. The distinguished speakers will be Professor Mo from Switzerland, Professor Mahul Amin from California, Professor Van Linders from the Netherlands, and Dr. Gerasit Surins Panot, I'm sorry for the misspelling, from Thailand. The webinars will be held on August 25th by this year. Keep updating from our website, our social media, then please join us for that webinar. On behalf of the President, Dr. Jeffrey So, we would like to thank you once more, Professor Berney, and Dr. Jeffrey So is attending this meeting, but he's just done a surgery. Let us pray for him. Speedy recovery, Jeff, for you. Thank you so much, and hope to see you in our next webinar. Thank you. I'll give the floor back to you, Meiji.